The HoNOS, or Health of the Nation Outcome Scale, was developed some time ago in the UK as a measure of symptoms and impairments in severe psychiatric illness. And as such, this measure has been very useful to describe the need for treatment in populations and also to reflect changes in symptom burden over time. The HoNOS can also be useful at the individual clinical level, and we've seen examples of how clinicians can use the HoNOS in clinical assessments with individual service users to help clarify the extent of symptoms and impairments experienced by those individuals. However, a further use of the HoNOS in the clinical setting is in the multi-disciplinary team, or MDT. In this case, as we'll see, it can help to structure and organize discussion about individual service users and the symptoms and impairments that they experience. Also, importantly, can help to structure discussion around interventions, be they biomedical, psychological, or social, to assist in the recovery of individual service users.
Name John. Review date 23/2/2010. Reason for review: routine 3-monthly MDT review and review changes and plan for the next 3 months. Brief background: long history of schizophrenia, on medication, auditory hallucinations, and he says alcohol helps. Current situation: he's living on the streets and alcohol abuse. Diagnosis: schizophrenia and alcohol abuse. Formulation: socially isolated, sleeping rough, alcohol abuse, and auditory hallucinations. Changes in the last 3 months: reusing alcohol. Concerns: HoNOS items scoring 3 and 4, alcohol and ADLs. Plan to address this issue: referral for alcohol assessment and referral for crisis respite and accommodation. HoNOS items scoring 2, relationships and hallucinations. Plan to address this issue: referral to daycare and query to increase his medication. Other concerns or goals not reflected by the HoNOS items: debt. Plans to address this issue: budgeting services. Top priority for the next 3 months: alcohol misuse.
Kia ora koutou, everyone, and welcome to our MDT meeting this morning. We've got 6 cases that we want to focus on this morning for our reviews. Robin, can you kick us off, please, with John Smith?
John's a 40-year-old Pākehā male with a long history of schizophrenia, and we did the HoNOS glossary score recently. He scored quite highly on the problem drinking and drug taking. His auditory hallucinations, which he describes as a white noise, and he says that the alcohol helps him. He's living on the streets, he's been excluded from supported accommodation, and he's drinking a lot.
Right, so how did he score on the HoNOS item on drinking?
Yeah, I scored him a 3.
How much is John drinking exactly? And what is he drinking?
Well, he's drinking 2 or 3 times a week, whatever he can afford really. He's buying cheap sherry, drinking the whole lot, passing out in the park, and putting himself in unsafe positions, really.
Right. So he's got a binge drinking pattern, sounds like. Is he also drinking in the morning?
I'm not sure if he drinks in the morning. On the 3 days that he can afford it, I don't know what time he starts.
Right. And does he see alcohol as a problem? Does he want to do anything about it?
He's probably in denial about his drinking. He doesn't see that it's that much of a problem. Well, he doesn't acknowledge that it's a problem.
So is he drinking alone?
Yes, I suspect so. He's quite socially isolated.
Do you think the score might be closer to a 2?
Well, if I refer to the HoNOSCA glossary of problem drinking or drug taking, number 3 talks about marked craving or dependence with frequent loss of control and some risk taking under the influence. And the fact that he's passing out, the other morning he came in, he was freezing because he'd spent the night in the park and had no idea how he got there. And to me that's loss of control, and it's really risky being in the park with unconscious. So yeah, I marked it a 3.
I'm wondering here if the number of the score is less important as to the agreement that clinically this is quite a significant case. And as the key worker, you will probably be the one that you will be the one that will decide what score would go down on that HoNOS. So I think we need to be in agreement that this is clinically significant.
Well,
Yes.
yeah,
Yeah.
definitely. Yeah.
Okay. So then from here, do you think we should be looking then at formulating a 3-month treatment plan?
Have you considered residential treatment?
I think it's a really good idea, and he's in denial about his drinking, so
In light of the denial and the social isolation that you've mentioned, maybe suggest some motivational interviewing.
yeah, I had that in mind, and probably to get him into residential rehab is a good idea. However, I think he needs probably to work with Bevan, who knows him quite well, to do the motivational interviewing, to get him even thinking about or considering rehab.
Yeah, I think that's fair enough.
You'd be willing to work with him again?
Yeah, certainly. Yeah.
Now we have a plan for John's alcohol issues. What is your next concern, Robert?
I think his hallucinations are quite a concern, and that's item 6, and I scored a 2.
Why a 2?
Well, from my assessment of him and going through the HoNOS with him, on number 6 it talks about voices and visions are present, but there's little distress to the patient or manifestation of bizarre behaviour that is moderately severe clinical problem. He talks about his the noise in his head that's always present, and it doesn't distress him, but it's always there.
Right. Sounds like a medication review might be in order. But yeah, before arranging that, I just want to clarify something that's possibly of diagnostic importance here. You did mention before, with regard to his drinking, that you reckoned that drinking either suppressed the intensity or the distress caused by the hallucinations. Is that right?
He said that the drinking helps his noises in his head, yes.
Right. I guess the concern I have is that maybe that could reflect the hallucinations arising out of alcohol withdrawal rather than from the psychotic illness that we're talking about more generally. What do you think?
He's had a diagnosis of schizophrenia for many, many years and heard this noise and had voices long before he started drinking.
Okay, so long periods of sobriety, but with continued hallucinations.
Yes.
Yeah. Okay. I guess that confirms the primary diagnosis of schizophrenia, but with this alcohol problem, if you like, added on top. It does seem like the issue of medication adherence might be quite important given his lifestyle.
He's on an injection and he takes side effect medication.
Right, so this is a fortnightly injection he's getting?
Yes.
Yeah, he comes into clinic daily during the week to get his side effect pill.
Yes, that's because I was concerned about where the medication was going. Sometimes he'd lose it and sometimes he'd say he left it in the black bag and he didn't know where the black bag was now. So for safety reasons I asked him to come in daily.
Yeah. Were you concerned that he might be selling it?
No, I think because of his lifestyle it was just too unsafe to leave it with him.
Right. Okay, so that seems to be working at the moment. I guess that point of contact each day is probably one, stabilizing factor in his otherwise disorganized life at the moment. It sounds like, even so, that review of the medication might be an idea. I wonder if I should try to see him this week.
That's a really good idea.
So far, so good, Robin. What is the next issue you'd like to discuss?
Item 9 talks about problems with relationships, and I've scored him a 3.
Why so high?
Well, he goes to the Baptist church and gets food there, and he goes to the community centre and he doesn't talk to people. If they don't talk to him, he doesn't bother initiating conversation. If he goes drunk, they ask him to leave. So he's pretty much on his own. He's quite isolated. And number 3 talks about active or passive withdrawal from social relationships, and that's where we came to.
Any suggestions for a treatment plan?
I wondered about the medication review that we've already arranged and whether that might be of some help with his withdrawal symptoms. He's obviously got some degree of active psychosis as well as this alcohol issue, and it seems to me that possibly optimizing his antipsychotic treatment will help with at least the first of those.
I agree with David. I think that motivational interviewing would be of some benefit, especially in terms of drinking and also lifestyle.
I'd like to suggest I do a needs assessment on John to identify his social needs within the community in order to put a wraparound service around.
Can you do a needs assessment while he's drinking?
To do a valid needs assessment, he'd probably need to be sober.
Right.
Okay. So just to clarify then what's going to be happening with John, Bevan, you're going to do the motivational interviewing, and that'll help with this issue as well as the others we've identified. David, you're going to do a medication review.
Right.
And Beth, you're going to do a needs assessment with him when he's sober. So was there something else you need to discuss, Robin?
Yes, the problems with his living conditions. He's scored a 2 on item 10, which is his problems with activities of daily living, but he's so unsafe on the streets that I believe that if we can find him somewhere safe to live, that a lot of his other concerns will be supported. And I think something urgently needs to happen. He's really vulnerable out there.
I'm not sure that's our responsibility, Robin.
His primary diagnosis is schizophrenia, and I'm concerned that he's drinking partly because of the positive symptoms of his illness, and that makes him really vulnerable to exploitation and puts him at huge risk, like he's passing out in the park and he's washing in public toilets. So finding him some urgent accommodation, I think, will help alleviate some of those symptoms.
Maybe we could look at the options of respite accommodation with the idea of looking long term and completing a needs assessment while he's sober.
Certainly sobriety would be necessary for longer term accommodation, and I guess the other advantage there is that you could actually do a valid needs assessment once he's dry.
That's right, yeah.
So what do you believe is currently the top priority for John over the next 3 months?
Well, I think excessive drinking is the main concern. What do you think, Robin?
Yeah, well, I agree. I think if we can, if your motivational interviewing helps him identify that he's going to benefit from rehab, that would be my desire that that's what happens. And from there he can get back into his contacts with people and into supported accommodation and have a life worth living.
Good.
Radio. Let's move on. Thank you very much. Kia ora koutou, everyone. Welcome to our MDT 90-day review. Robin, can we start with you, please, and John Smith?
Sure. I reviewed the HoNOSCA with John recently, and I'll just remind you what we looked at last time. We looked at his alcohol misuse, his hallucinations, his relationships, and his living situation. I think that we've made some progress. Do you want to talk about item 3 is drinking, Bevan, because you were going to do some work with him?
Sure. I've been seeing John regularly since our last meeting for motivational interviewing, and he was in the pre-contemplative stage. That's now changed. I just want to remind you, this pre-contemplative, contemplative, preparation, action and maintenance. And I think John's in the contemplative stage now, contemplative in the sense that he's now thinking about his drinking, and I do think he's actually drinking less.
John said he's been finding it useful meeting you, and he's now talking about residential rehab, which is great that he's considering that. Despite the improvements, he still scored a 2 on the HoNOS, and I'm going to continue working with him and work on our treatment plan with him. But yeah, there's definitely improvement. He's come down from a 3 to a 2, so that's a bonus.
David, can you update the team, please, on item 6, problems with hallucinations?
Yes, I saw John after our last discussion 3 months ago and reviewed his medicine. As you know, he's on a regular depot, which he seems to tolerate pretty well, but he didn't have a full response in the sense that he was still suffering quite a lot from hallucinations at that stage. I decided to push the dose up and have reviewed him again recently. It appears that the hallucinations have subsided in terms of how intrusive they are and also how distressing they are to him. So I think we're making some progress there.
Yeah, I'd agree. And he's scoring a 1 in this area now, and it's no longer clinically significant, but of course we'll keep monitoring for that, seeing how he goes with it.
Yeah, I think very, very important to ensure that he continues to receive his medicine. The other thing I wondered about, given our discussion last time, was the relationship between his hallucinations and his drinking. It seemed that his drinking was in part due to the fact that he found it helped suppress the hallucinations, if I'm recalling correctly. And thus, with those hallucinations now relieved by the medication, is that possibly one reason why he's drinking less at this stage?
I'm sure it has, and I think that his drinking now is probably from boredom and because it's just a pattern that he got into, but it's certainly improving with the work that Bevan's doing with him.
Okay. So how is John going for item 9, problem with relationships?
He's indicated that he wants to be more involved with people, and he's attending some of the support services, but he still finds it really difficult to engage with others, and so he spends quite a lot of time on his own.
What did you score him for that one?
A 2.
What plan do you have in mind?
Well, I'm going to see him fortnightly. He set a goal himself to be more engaged with people, so we're doing some role plays of how he can kind of introduce conversation to people, so that seems to be working quite well.
Okay. And how's John's living situation in item number 11?
I've completed a needs assessment which indicated that supported accommodation would be beneficial to John. He's declined that, so he's living in a boarding situation with friends from the church and appears to be really happy with that situation.
He is happy in the boarding situation, although while his drinking remains a problem, he's still rating a 2 on the HoNOS. But what's more clinically significant is that his mood has really dropped. He's quite depressed, and I had to score a 2 on the number 7 on the HoNOS, which is around depressed mood.
Right. I mean, I must say the depression wasn't that obvious when I saw him a fortnight ago, but I take it that people have generally noticed his mood is lower. Is he showing any signs of self-harm?
No, he's not suicidal nor does he have any thoughts of self-harm.
I've also noticed that John's got a depressed mood, and I'd suggest that we introduce CBT in the current treatment plan.
Right. I wonder, given the fact that his psychosis is much improved, perhaps this depressed mood represents either post-psychotic depression or alternatively a side effect of the increased dose of the antipsychotic. So I'd actually like to review him again to explore that.
And the drinking could be a depressant as well. So yeah, I think that's a really good idea that you see him again. I am concerned about his mood.
Right.
So is everyone happy with that?
Indeed.
Yeah, lovely.
Okay.
Thank you.
I think we're doing really well with it.